Impact of this coronavirus pandemic on the operations of Mediheal Hospital. Mr. Kumar, let's start with you.
Once again, a very good morning to you and the audience. Thanks for hosting us this morning here.
Pleasure.
To elaborate and to talk about the healthcare, how the landscape is changing in this part of the world.
Indeed.
Definitely globally, I think COVID pandemic has made a very, very strong impact in terms of if we have to divide the entire healthcare system, it will be pre-COVID and post-COVID. You know, how things would be managed moving forward, right? Operations wise, let's say a lot of challenges which are built in because of the pandemic, right? And pre-COVID, it was a different era, how we used to manage the operations, but post-COVID has been completely different in terms of triaging the patients, in terms of managing the patients. But all said and done, you know, we are towards the end of it, but it has definitely had an impact, opening avenues for newer technologies, especially, let's say, digital technologies like telemedicine and teleradiology and things like that. So that it has opened and it has fast-tracked the process, which would have been, let's say, accomplished in the next 8 to 10 years' time. Now, there's a need that, you know, we bring it fast forward and make it available right now in the current scenario.
I'm looking at a situation whereby you're in a lockdown. There is a patient that needs a kidney transplant. Is in a very remote area. You are trying to reach them. There is a lockdown. Talk to me about those problems and challenges that befell your operations during the pandemic. How were you able to circumvent or, you know, circumnavigate all those challenges?
Yeah. So initially what happened, patients used to directly come even for pre-evaluation if once the patient has a chronic kidney disease, and probably Dr. Murthy would elaborate more on that.
Indeed,
but currently what we're trying to do is, as we have a satellite, you know, centers in different parts of Kenya and also in different parts of the country. In Somalia, in Sierra Leone, in Congo.
You have satellites in these countries?
Yes, we have satellite clinics in these countries, so that the patients get connected through telemedicine with the primary clinician who is actually evaluating the patient on a day-to-day basis. So we see their reports and the records available, and then try to put them on medical management if possible for some time. And then when it becomes very important for him to undergo the transplant, then Dr. Murthy and Dr. Sanand Bag, who is a part of the team, will come into picture.
That is really, really amazing. What are the healthcare needs for which people fly abroad for?
What we have seen, Mr. Romeo, is that if you look at conventionally, you know, when people travel to countries like Turkey, to South Africa, to India, what has been mapped out is for ailments like cancer management, cardiology, cardiac surgeries, kidney transplant, and organ transplant, basically liver, heart and kidney, and then joint replacement, advanced neuro, brain and spine surgeries. So these are the areas broadly where we have seen that the patients travel. In the last 5 to 8 years at Mediheal also, we have been trying to focus a lot on these areas as focus specialties, and we have built capacity in terms of technology, in terms of medical faculty and the newer technologies that are available. So these are the areas where people usually, even from the other parts of the country, they travel to Mediheal in Nairobi and Eldoret.
All right. Yeah. Let's also bring in Eos Murthy, the chief transplant at nephrologist at that is Mediheal Hospital. So let's talk about the issue of kidney disease, kidney failure. What is it about? What causes it?
Yeah, see, kidney disease has become now a common name with every man.
Indeed.
And now everybody is aware of it. Now, as you said in your first question,
yes,
what is the impact of COVID on the healthcare delivery systems? One good thing, bad thing, okay, we suffered badly. We failed to defeat it. We are praying that it subsides. Now that it has brought even medical awareness to even common man, which even hundreds and hundreds of lectures by doctors would not have done it. So to say that awareness about lifestyle problems.
Lifestyle problems.
Yes, they are the lack of awareness. So missing treatable conditions like high blood pressure.
High blood pressure.
Like high blood glucose, that are diabetes. And then the unnecessary pain killer intake for routine simple ailments. Prolonged intake.
Prolonged, yeah.
Instead of adjusting our lifestyle and making it healthier, we tend to either ignore the problems and land in trouble.
So self-medication is a problem.
That is one of the problems.
When I take too much ibuprofen,
yes,
paracetamol,
something like that,
it will affect my kidneys at some point.
Prolonged, without a medical consultation, going through a thorough checkup, particularly early in the period. When you miss the first point, And by the time they come to me, people like me, it is already fairly advanced kidney disease, wherein we cannot reverse a chronic process.
You cannot reverse a chronic
process because the damage is irreversible by the time they see the real specialist. Actually, the real prevention is from the primary care doctor, the family doctor, who will pick up the risk factors. But by the time they come, the real specialist steps in, particularly in kidney. The damage is fairly advanced. And then I put them on dialysis, and then I do transplants, which should have been averted in the first place when you have picked it up in the right time.
I've also been doing some reading, and I noticed even though you do a transplant, this person stays with the kidney disease, and they still have to take medication for kidney disease.
He doesn't stay with kidney disease after transplant. He remains a healthy person, but should be taking medicines. Like
for the condition he had before?
Yeah, no, to keep the kidney in place.
I see.
So that the body accepts it. See, kidney transplant, for kidney transplant, surgery is just the first step. You have to take it properly. After that, the real problem is that the body should accept it. It's a foreign tissue in your body.
Indeed.
Malaria, tuberculosis, or whatever, kidney, liver, doesn't make any difference to the body. So the body tries to reject it, and we try to suppress it so that the body accepts it. So that is the crux of kidney transplantation. You do take medicine, but you will not be sick.
I see. So you did tell us what causes kidney disease: type 1, type 2 diabetes,
Yes,
high blood
type
pressure,
1 and type 2, the high blood
self-medication.
pressure. And there are so many other genetic causes which are particularly peculiar in different parts of the world. Here, there are in Africa. There
I
are
can get it from my parents.
Yeah, why not? Yes.
Okay.
Many diseases, even high blood pressures, diabetes go through families, type 2 diabetes go through families. So even kidney diseases, there are particular genes which will make you prone for disease. So they do get in the genetic inheritance get inherited.
So how do I know that I do have kidney disease? What are some of the signs and symptoms to look out for right now? If I'm watching Morning at 10 TV, how
More
would I know and be
particularly
able to
to
identify?
say, many diseases, they announce themselves very early. They produce symptoms and signs, but medical kidney diseases, I just want to make a clarification here. The symptoms and signs of kidney disease mostly are due to kidney stones,
Okay.
the prostate, and then the obstruction to kidney tract by stones or tumors. These are symptomatic.
Yes.
When there is an obstruction, you get a symptom. If you have diabetes and pressure, it slowly kills the kidney over a period of a decade, which you miss it. It is not the patient who picks it up. It is your treating physician, family physician, an alert primary care doctor who will pick up and say, hey, you have a problem. So there is a difference in the patterns of the disease when they announce themselves.
Indeed.
So mechanical problems like stones, it is a disease, but it announces early. But that is not the main cause of kidney failure.
Yeah.
The real causes are our lifestyle.
Indeed.
Overall, I'm not saying Africa, India, Europe. No, little with a 10% difference, more or less humanity is same now. So lifestyle is also becoming same.
Indeed.
Diseases are also becoming same. So either they are communicable, like infections, or non-communicable, like lifestyle diseases.
Indeed.
More or less, they are the common causes of kidney failure in the chronic phase.
Indeed. In the chronic phase.
Yes.
Now that you talked about the chronic phase, what are the 5 stages of kidney disease?
Now, see, as I told you, since many of the stages pass through so silently that
Low,
you reach
moderate,
stage 5.
acute. Yes.
See, stage 5, I'm not talking of end of life of
Yes.
the individual. That organ, when you pick it up early, we call it a stage 1. So during some other, say for your recruitment, for employment, you went in for a health check.
Right.
They found a very minimal trivial problem. We will write it as stage 1. Say kidney function slightly damaged.
Indeed.
Yeah, but still 90% okay. That's something like that, 60 to 90s. Then we say, okay, a little more damage. Now the trouble starts from stage 3. Oh, you start
Stage
getting alert.
3, moderate.
More strict. Hey, don't eat this, don't eat that, don't do this.
Yes.
So all these don'ts and do's starts. But when the kidney function reaches less than 10 to 15%, now now the individual is in trouble. Life is at risk.
Chronic.
Yeah, other stages are manageable just by medicines, do that, do then, don't do this. But now the trouble starts with stage 5, or simply, let us put it more simple, less than 10%. Less than 10% kidney function is not sustainable for the patient's life. It creates risk. He lands in problem. The water gets retained, all the urea, creatinine, sodium, potassium, acid, they build up, the individual throws up, he can't eat. Now this is where so-called dialysis or the mechanical kidney comes into place to keep the individual alive, but not treat the kidney disease. It is a machine that does the function of the kidney, that is the cleaning.
Yes.
Now transplant is a better option.
At stage 5.
Yes. Or even little early. Around the stage 5 is one when somebody needs a mechanical kidney or a natural kidney. Natural kidney is better because machine only cleans, but natural kidney gives you a little more life. It gives you, that's what I said, they will remain healthy, they go back to work, they become productive, they're not a burden on the society or himself.
But they have to continue taking medicine.
That's a must. Even if you have pressure on diabetes, are you not taking medicine?
Natural kidney and the mechanical kidney. What happens here with the mechanical kidney?
This is the other name is dialysis. I just want to make it clear that dialysis is not treatment to kidney failure. It's a replacement. It's a replacement. Neither is transplant treatment for your disease. The disease will remain.
Yes, Dr. Murthy.
If you are again negligent, this kidney will fail. Both are kidneys. The negligent person is same. Or the negligent doctor, whosoever it is. So, I mean, the doctor negligent means he is missing it. He doesn't know where to pick, whom to refer, and how to treat. If he doesn't know, at least he should say, hey, go to this fellow. So that he is addressed. So, the first priority in kidney disease is to prevent it.
To prevent it. How do you prevent kidney disease?
That is what the people should be aware that we should take care of our lives, have some time for ourselves, see that our daily lifestyle, we keep our weight under control, our pressures under control, diabetes under control, and every health check, say after 40 years, a couple of years, have a good health check. Once in a couple of years at least.
Indeed.
So now, high blood pressure has become so common, even after 35 plus, 15 to 20% of the world population has become hypertensive.
Indeed.
And then diabetes, 5 to 10% are becoming diabetic. Young people. So now that is where the trouble is starting. That is okay, but that is not the problem. That we mismonitoring it is there where the crux of the problem starts.
I see.
And then at the end of the story, we put a great color saying transplant. Transplant is when you are condemned to dialysis, transplant gives you a better life. But the problems remain. The problems remain. They need to be controlled.
Indeed.
So that you are back to your work and productivity, so that you sustain yourself, most important. The central core point is that individual is not dependent on anyone, not a burden to the healthcare system. Because these chronic diseases, ultimately they become a burden on the healthcare system.
I see.
Yes, because it's a chronicity. First thing is, treating itself is costly. And second is, the individual is not giving anything to himself or to the society. So either way you lose two ways.
Indeed.
The country or the economy becomes, it's a burden. Dialysis is a burden.
Indeed.
Yeah. A transplant is less burden, but still at least because the individual creates something back.
Yes, doctor.
He is back to his profession. He's a doctor, he's a doctor, he's an engineer, he's a technician back.
That is Dr. A.S. Murthy, Chief Transplant Physician and Nephrologist with Mediheal Hospitals. He comes with a wealth of information like you've been hearing. We also do have Dr. Gokul Kumar, the Vice President of Mediheal's Hospital. We'd like to know what makes these operations or kidney procedures so expensive, Mr. Gokul Kumar. In Kenya here, it is cheaper. So what makes it expensive in India?
It's a very interesting question, Mr. Romeo. You see, this kind of procedures, especially let's say organ transplant or very advanced brain and spine surgery, which we call as endoneurosurgeries, cardiology, cardiac surgeries, were confined to the first world countries not very long ago. If you look at the pattern, how the healthcare system or the landscape of healthcare is evolving.
Yes.
Right now, it's a holistic game basically. Right. People used to flock to India and to other countries. It's because of the good treatment options and at the same time good affordability in terms of pricing. So what at Mediheal, the founding chairman Dr. Mishra, Honorable Dr. Mishra, who's the chairman of the organization. He had the vision that Africans should be treated in Africa. This is about 15 years journey that we have been so far. Keeping two things in mind. One is making the healthcare accessible, and also one is affordable. Now, in that affordable aspect, there's always a room how you play around the things, you know. The cost, let's say, in terms of consumables, the cost of the physicians or the surgeons or the theater or pharmaceuticals, how you manage them and bring the cost down. Because if you want to compete with countries like Turkey or South Africa or India, though you provide the best of the services, if you can't make it affordable to a common man, it would be very difficult. But what we have seen in the last few years is that, this game is slowly changing. You know, it's becoming level playground now for people, right? If you look at our transplant itself, we have done more than 210 transplants in the last 2.5 years. Now, that's a phenomenal number to talk about. Probably, Mediheal would be the only institute in the entire of Africa accomplishing this task of 210 transplants in 2.5 years span, right? I'm on record, actually. So, what I'm trying to say is, when we give good service, so Africa, one, it becomes self-reliant, which COVID has taught a big lesson, that every country should have the self-sufficiency in terms of when it comes to healthcare, because we have seen the lacuna in terms of infectious disease management, not having ventilators, not having ICU beds. It has thrown up a lot of challenges open to the healthcare system to revamp the entire system and to build the skills, to build the capacity, to build the infrastructure and all these things. So what we're trying to do is to compete on a high platform, not compromising on the clinical outcomes, okay, with the latest of the technology. If you look at the gadgets that we have, all comes from Germany and from US, because if you need to have the best of the clinical outcomes, you need to have the best of the equipments, best of the doctors and best of the consumables and the pharmaceuticals. So all these things put together, and at the same time, you always have room in the healthcare, how you play around with the things and make it affordable. Now, there are two kinds of model basically. Let's say you make profit from one patient of 100 shillings, or you make the same 100 shillings from 10 patients. And we believe in the second model of the low-cost business model. You make little profit, but from more number of people, so that you serve a large number of people.
Dr. Gokul, what are some of the other services that you offer in Kenya at Mediheal hospitals, and how are they competing with other destinations like South Africa, of course, India, Turkey, if you will?
Yeah. If you look at the statistics, last couple of years back, because pandemic was different ballgame altogether.
Indeed.
Africa spends almost about 3.8 billion USD treatment abroad, Africans. Either they go to Dubai or Turkey or whatever these destinations.
Indeed.
So it was about almost like $3.8 billion, okay? So that's the size of the market we are talking about, only from Africa. Now there's different market zones, like Southeast Asian countries, most mostly to Singapore, and then Africa, mostly to Turkey or to India. So that's how the mapping has been done. At Mediheal, what we've been trying to do for the last 15 years is that building capacity of the specialty. Now, organ transplant, both kidney and liver is just one part. We have the state-of-the-art cardiac services. So we also encourage our people, for preventive medication, right? So we offer executive health checks, and then cardiology in terms of interventional management, cardiac surgeries, advanced brain and spine surgeries, and IVF services. People come from all over the region for IVF services, and also joint replacements, including sports medicine. So by and large, from end to end services, even the patients who are coming from abroad, we created the entire ecosystem, right from a query generation from the treating physician in that particular country till the patient goes back. Even if it is required, air evacuation is also being done from countries like Congo, Uganda. So all those services are provided at Mediheal.
Indeed. There is Gokul Prem Kumar, the VP Vice President for Mediheal's hospitals. We also do have the Chief Transplant Physician and also nephrologist at Mediheal's hospitals. That is Mr. Dr. A.S. Murthy. Dr. A.S. Murthy, 200 kidney transplants in 2.5 years. Astronomical milestone, I must say.
Yes.
How was this, achieved? Can you explain to us, step-by-step basis? 2.5 years, 200 transplants.
Yes. Like you said, the COVID logistics hit everyone, including the transplant activity.
Indeed.
Way back just a couple of years ago. We had to stop transplants even for 6 months at the peak of COVID season.
Yes.
Then we started learning how to circumvent the COVID, and I don't know if I say it is true or not. We may be the highest number of transplants maybe in the world during the COVID season.
Indeed.
Because to be, if I give the stats with a little 90% correct data, I have lost a lesser number of transplant patients than general public due to COVID. I can count the number of transplant patients whom I have lost to COVID on fingers.
Than the kidney failure itself?
No, than the general public, general people. If 3 or 4 out of 10, 15 patients have died in the common, my transplant patients I can count 3 or 4.
I see.
In my 100 transplants in the COVID season.
So as more people die over COVID, fewer have died.
No, the point is trying to make is transplant patients or the patients on dialysis, cancer patients, they're more vulnerable when it comes to COVID infection. So what it's trying to make is, despite, actually if you look at the trend, these people should have been more. If 10...
There should be more mortality among my patients.
Absolutely.
From your patients.
Yes.
But I did not observe it. I don't know if it is true across the world. But that was what encouraged us to go ahead with the transplants despite COVID being rampaging all over, and now it is leveling it off. But the precautions we took, like we vaccinate before transplant all these patients, and then we give for high-risk patients some prophylactic COVID medicines if we see that the patients are vulnerable, immediate post-op. And then one of the reasons for such phenomenal numbers was, in my 20 years of nephrology practice, so I have been transplanting in India also 10 years ago.
All right.
For the last 4 years I've been here. So the protocols which we developed, my team, myself, I'm the physician, my surgeon, Dr. Bag, and my anesthetist, Dr. Vajnath, and his team. These protocols were developed from the local people. What suits these people, not what India wants to do here. That is not the one which we developed.
Well said.
Bottom-up approach.
This is suited to these people here. This is what we observed. So then I modified all my protocols, which I learned in India. I set them there. I said, now let me do this way.
Indeed.
Now my data are coming up officially. Maybe in a couple of months I will be publishing in any scientific journal.
And it
minute details.
Yes.
So the protocols went into the people nicely, with very good outcomes. I can say if I do a last 100 transplants, I was 98% successful at 1 month. Yes, a couple of difficult cases like very sick people, old people, or some. But
chronic
I could
cases,
say if I did 100 transplants, I could deliver 98 almost at 1 month,
That is
and 95% after 3 years of they're still doing well. They are still doing well, they're back to their jobs, their families, their work, everybody. And these are real-time data. I capture the data, real-time, their follow-ups, their workups, everything we capture and we share it with the people and with the scientific community, with the media and with the governments. This is what I'm doing. And this is why people have accepted it.
Indeed.
So that is the core reason. Apart from our technical capability, okay, that's okay. I'm a little senior doctor, and my team is also all are 10, 15 plus years experience, all of them.
Yes, doctor.
Yes, so that is okay, part of the story, but that the people have accepted it, and that is their trust is the core reason for the success.
Doctor, how severe is the problem of kidney disease within the East African region, especially Uganda here? Because it's terrible in Nigeria. I don't know about India. You can talk to us about how dire it is in India and paint for us a picture within the East African region. Uganda especially.
More or less in the third world countries, see, when we look at humanity as a whole, overall lifestyle, as I said, is becoming more or less similar.
All right. All over the world.
No, yeah, almost. It is catching up now, modernity catching up with food and lifestyle, more or less, the transport, the inactivity. So more and more are we uprooted from our nature, particularly say African people are supposed to be more near to the nature, but we don't see they are also equally uprooted now. modern people now. Africa is also becoming modern, so diseases are modern. So with little differences, as I said, in the African region, particularly Uganda. This is the second time I think I'm coming. Second time. And overall in the African regions, as I said, missing the basics is the problem. Missing the basics, the disease is diagnosed at a very late stage. That is the crux of the problem, both in India and here.
So we need to test early, one of the solutions.
Yes, the early detection of the disease is the key crux so that we should target, so that we should not have transplant or dialysis. We don't want our brothers and sisters or fathers and mothers dying of advanced kidney disease, be it dialysis or be it transplant.
Indeed.
That should be the aim of every doctor and at every healthcare provider, anywhere part of the world.
All right, besides early testing, Gokul, what other solutions are available for someone with kidney disease?
As Dr. was rightly mentioning, that depends on the staging of the progression of the disease. You know, as it's controlled at the very early stage, still can be managed on medical management. And then, once it crosses certain stages, then probably the patient is on dialysis. But he has rightly mentioned, the transplant is the ultimate option for the patients to undergo. So those are different options that are available for the patients. But I was also asking the geography wise, like, what we have seen is these 210 transplants that we have done in Kenya, right? We also have patients, let's say, from Uganda, a more number from Somalia, I know particular reason, probably doctor should be able to throw more light on that. Apart from patients having from Burundi, from Congo, from all these countries, but we have large numbers of patients from the Horn, Somalia and that region. Yeah.
Okay, one of the solutions we've mentioned, get tested, another, get a transplant, but what if I do not have the money to cough, all those fees? What do I do in that event if I do not have the money for the procedure?
No, the problem is transplant is a better option for end-stage kidney disease, but not the only option. Like many people, a few people are not fit for transplant, like very old people, like very young people. My youngest transplant is 8 years.
8 years.
8-year boy. For some reason, the kidney was not even formed well. So, and then the parents brought the boy, and we transplanted. The boy is doing well, and even now grow well.
That is amazing.
Isn't it? That's a grow well. But so, as I emphasized, the whole crux of the problem should be not to enter the stage of requiring dialysis.
Indeed.
Because once you enter that, now even if you have affordability or non-affordability, now your hands are tied. You have to make him alive somehow. So if transplant is not a possibility, then good dialysis. A good dialysis is very costly on governments, providing adequate dialysis. So many countries in the third world, they end up providing only twice-week dialysis sometimes, which is many times not sufficient. Even in India, it is not sufficient. Yes, even I have the government institutions provide 2 dialysis. The patient, poor fellow, pays for the third one. To do well and then go back to work and provide for his family.
Indeed.
So affordability is always it's a bigger issue than medical technology.
Indeed.
Like business, Mr. Gokul knows better about healthcare costing.
Yeah.
That is a bigger scenario where the government should come in, the policy should come in, and then how to ensure these people right from day one of their lives, so that later in life such kind of costly treatments should not be a burden either to the individual or to the governments.
All right. Now, before I let you go, Mr. Gokul, what do other African governments, especially here in Uganda, need to do to increase capacity and also build our health infrastructure to handle chronic diseases like kidney failure?
We have been trying to have conversation, with like-minded doctors and like-minded institutions.
Go ahead.
Like-minded institutions and like-minded doctors, that when we say transforming healthcare in Africa, right? So you, as you change the landscape, try to share the best practices that are being done at Mediheal, right? So that you build the capacity with other countries, with other people.
Sharing best practices.
Sharing best practices and capacity building, so that you transform and multiply the good work that's been happening at Mediheal in Kenya. We also have our hospital in Rwanda. Soon we'll be in Uganda and the respective, different countries like Kinshasa, by God willing. Right, so that's how we are trying to make these specialized services more affordable and accessible to the people, by and large, Pan-Africa.
Very insightful conversation with Dr. A.S. Murthy, the Chief Transplant Physician and Nephrologist at Mediheal's Hospital, and also the Vice President of Mediheal's Hospital, Mr. Gokul Prem Kumar. Gentlemen, thank you so much for giving us your time and sharing this information.
Thank you, Mr. Romeo, for hosting us once again. It's been a pleasure talking to you.
Indeed.
Thank you so much.
And of course, you're still watching Morning at NTV, skyrocketing fuel prices are biting, and the border riders in this country have not been spared. A barrel of oil on the global stage is going for $113. That is how dire the situation is unfolding. Those details are coming your way shortly after this break. We'll be right back.